All right, well, good morning, everybody, and welcome to Ground Rounds. It gives me great pleasure to introduce Dr. Dean Kereiakes. As I was checking online, this is our first outside speaker in a long, long time. So I think it signals, a return to normalcy, hopefully. Dr. Kereiakes is president of the Heart and Vascular Center at the Christ Hospital and also professor of medicine at Ohio State University. He received his medical degree in Cincinnati and then completed his cardiology fellowship at the University of California in San Francisco. As I was looking at his contributions to medicine, I was very jealous last night. He has been involved in every single major development in the field of interventional cardiology, from the first drug-eluting stent trials to the partners trial, bioabsorbable stents, intravascular lithotripsy. Really an amazing career. So we're really delighted to have you here today with us, Dean. Please take it away.
Thank you. Thank you very much for the very gracious and very generous reception. I really appreciate it. Thanks for last night, Chris, and the opportunity to be here. I'm going to talk about novel coronary interventions on the horizon. Kind of eclectic: stents, balloons, lithotripsy. The only device that's actually recently been approved by the FDA that I'm going to talk about today is lithotripsy, believe it or not. So that puts it in perspective. What we're going to talk about is devices that I expect to be approved by the US FDA this year and devices that will go into IDE trials this year that you should be aware of. These are my disclosures. I've been a consultant for most of the catheter companies for the last 25 years. And indeed, for the last 25 years, there's been a remarkable evolution in PCI, from bare metal stent to first generation DES to second generation DES. And through that evolution, we've seen a progressive stepwise reduction in adverse stent-related events, whether it's the device-oriented composite endpoint of target lesion failure that you can see on the left, or whether it's simply stent thrombosis. The lowest incidence of events from implantation to 1 year is seen with second-gen DES, followed by first-gen DES, and then bare metal stent. Now, progressive iteration of the device has progressively reduced the 1-year incidence of adverse events, but as you can see, beyond the first year, there appears to be a 2 to 3% per year annualized event rate, regardless of device. And the major driver in that progressive reduction in adverse events appears to be a progressive reduction in stent strut thickness. If you look on the left, we see a progressive stepwise reduction in stent strut thickness, and this is a network meta-analysis of 66 trials and 75,000 patients. And this is associated with a stepwise progressive reduction in stent thrombosis. Similar significant relationships for both major adverse cardiovascular events and myocardial infarction were also demonstrated, all of which point to the fact that thinner is better when it comes to coronary stent struts. On the left, you can see the inverse relationship between stent strut thickness and the degree of strut coverage in a finite period of time. Thicker struts have less coverage, more fibrin, more inflammation, greater injury index. Strut thickness affects thrombogenicity. On the bottom right, the thicker strut creates a zone of low shear stress downstream behind the strut that is intrinsically thrombogenic. This is a point we'll return to. This direct relationship between adverse outcomes appears to be magnified between stent strut thickness and adverse outcomes, appears to be magnified in smaller vessels. This is the Bioresort pre-specified analysis of small coronaries. This is a visual estimate RVD of less than 2.5 millimeters. And you can see for both target lesion failure on the left, target lesion revascularization on the right, the landmark at 1 year. Beyond the first year, there appears to be a progressive stepwise reduction in the annualized rate of adverse events, with the lowest rate of events seen in the patients treated with the thinnest strut device. Now, the Bionics trial adds something, insights, I think, into strut geometry that can mitigate some of the impact of strut thickness. And let me sail this out there as I think where the field will go in the next several years. Bionics randomly assigned 2,500 all-comers to treatment with either the Resolute Onyx 81 micron thin round strut device or the Osiro 60 micron ultra thin square strut device. Target vessel failure powered for non-inferiority at 1 year is the primary endpoint. On the left, no difference in target vessel failure to 1 year between the randomly assigned devices, and on the right, ARC definite probable stent thrombosis, 0.1% Onyx, 0.7% Osiro. Both look pretty good, but this is a highly significant, almost 90% hazard ratio reduction in favor of Onyx. You should also know that there were 38 2mm Onyx stents in this group, 2mm diameter stents in the Onyx group, no 2mm stents in the Osiro group. The smallest stent diameter there is 2.25, and you know that smaller stent diameters have a proclivity for thrombotic events. The isolated thrombotic event in the Onyx treatment group was a patient who got over 100 millimeters of stent and stopped their dual antiplatelet therapy inappropriately within 30 days. Now, some called this play of chance. This is a fluke, right? But if you follow these patients out to 2 years, as shown here, there remains a 62% relative reduction in stent thrombosis in favor of the thicker but rounder strut device. Play of chance, I think, could be operative here. I think play of strut geometry that affects strut level shear stress distribution is probably operative as well, and I want you to consider that. Square strut has the worst strut level shear stress distribution profile, the greatest shear stress abnormality. This is 95% of the stents we put in for the last 25 years. Every one of these configurations, whether it's round or circular, like Onyx, elliptical, or teardrop, have better shear stress distribution profile, less shear stress abnormality, peri-strut shear stress abnormality. If you embed the Onyx in the Osiro at a 16 atmosphere deployment, if you deploy both of these, the top two, the one that has consistently better embedment is the circular strut. This can facilitate endothelial cell coverage and healing, and it also has better shear stress distribution, less shear stress abnormality, as you've already seen. So the point that I'd make is that thinner is better at the end of the day, and I suspect you'll see the industry move toward this. Thinner and rounder may be best. Now, a rounded strut device, due to very aggressive polishing, it's thin at 81 microns. It will be approved by the FDA this year, I believe, is from Svelte. Were you guys in the optimized trial here by chance? No. Then you need to know about this because Svelte comes in two versions. One version is the IDS, Integrated Delivery System, you see here. This is the lowest profile DS system available anywhere. It is literally, figuratively, a DS on a guide wire using Asahi wire technology. The 2.5 stent is a 31,000 crossing profile. The 3.0 is 32,000. This is less than the caliber of the wires we use for vascular access. It'll fit comfortably in a 5 French diagnostic catheter, doesn't really need a guide, and the polymer is a unique amino acid composite called PEA or discrete that undergoes enzymatic erosion over 12 months, not hydrolysis like the PLA derivatives. Well, Optimized was a pivotal trial for US FDA approval. Sunil Rao was the co-principal investigator with me on this project. It's a prospective, single-blind, one-to-one randomized, active-controlled, multi-center, non-inferiority trial, the objective of which was to compare safety and efficacy of Svelte IDS and the second version of the device, the monorail catheter, the RX, with Science Promise. Now, Optimized is the first IDE trial to evaluate direct stenting, to have a transradial focus, to assess a new DES delivery system, which was the IDS, and also to assess a new class of drug coating or polymer, which is the amino acid composite. I want to point out that randomization in this trial was stratified by the intent to direct stent. So we created a randomized trial within a trial based on eligibility criteria for direct stenting shown here on the right. Now, the direct stent portion of this trial was capped by the US FDA at 30% of study subjects. There's also an angiographic and IVUS sub-study that we'll come back to in a minute. Through 12 months, There was no statistically significant difference in target lesion failure or any of its components. As you can see here, some of these, such as clinically indicated TLR, are very low, 1.5% was felt. Through 12 months, there was no difference between the devices. With respect to all stent thrombosis, numerically slightly favors SVELT, 0.38 compared to 0.51%. And an interesting observation in the angiographic and IVUS sub-study was that incomplete stent apposition was significantly more frequent with Science Promus, both post-procedure and at 12 months, and actually was zero in the SVELT group at 12 months. So this may in part reflect the fact that the SVELT device has a non-compliant balloon on its delivery system, that there was, on average, a statistically significant greater than 1 atmosphere higher deployment pressure in SVELT compared to Science Promus, but also that these operators, as you know, are not blinded when they're putting in the device. With respect to target lesion failure in the ITT intention to treat analysis at 12 months, SVELT was 10.3%, Science Promus 9.5%, the p-value for non-inferiority 0.034. Less than 0.05, but didn't quite reach the pre-specified level of statistical significance, which was set at 0.025 to prove non-inferiority. So the soundbite that came from TCT was that SVELT missed the mark, optimized, did not hit its primary endpoint. I can assure you this is not because of device underperformance. Bram Zuckerman and the FDA get this fact very clearly. It was because of trial design, and this is the inside. The trial was designed by BAME HCRI. This is the statistical design. The expected TLF or TLF estimate was set at 6.5%. This was taken directly from the control group in the EVOLVE-2 trial, which was Promus element plus treated patients. That 6.5% observed TLF came with a component endpoint diagnosis for TVMI that was established using CK-MB in 91% of patients, total CK in 8, troponin in only 1%. Only 1% of all the patients enrolled, 1,684 patients enrolled into EVOLVE-2. I know because I was the PI of that trial as well. Had troponin, period, 1%. We'll come back to that. The fixed non-inferiority margin, 3.58%, is perfectly consistent with the FDA guidance document on non-inferiority trials. This is a 55% relationship of total TLF and a 1.55 relative risk. Well, this is what happened. This is 12-month target vessel MI by biomarker and device. TLF was driven by TVMI, and 90% of TVMI was periprocedural. No surprises here. 25% of all the subjects enrolled into Optimize had only troponin drawn as a biomarker. 36% of these were high sensitivity troponins. That 25% accounted for 80% of all the target vessel MIs. If you look to the right of patients assessed with troponin I, which includes our entire population at the Christ Hospital, over 30% were diagnosed with a target vessel MI, and there was no difference between the devices. Troponin T, over 10%, no difference between the devices. If you had CK or CK-MB, which is 99% of what we did in EVOLVE-2, it's 2.5% or less. If you couple this with the fact that the definition of TVMI in this trial required a greater than 3-fold upper limit of normal for either CK-MB or troponin without requiring clinical, angiographic, or imaging correlates, this was the recipe for driving high rates of TVMI, subsequent high rates of TLF, and progressively underpowering the study. The power estimate, believe it or not, I didn't present this at TCT, for the number of patients we enrolled in the observed TLF we have, the power estimate's under 60%. Because of this, BAME recommended several post hoc analyses. The first of this, that we did was a relative risk analysis and compared to other contemporary IDE studies. Now, relative risk reflects the difference in TLF rates across these treatment groups, SVELT versus Science Promus. The relative risk in Optimized is 1.09. Even the upper confidence bound of that falls well within the pre-specified 1.55 non-inferiority margin. If you look at the relative risk with optimized compared to other contemporary IDE studies, Evolve2, Bioflow 5, Bionics, Absorb 3, all of which proved non-inferiority of the test compared to the controlled device, the conclusion is very clear. Svelte was not inferior to Xience Promus. Two other analyses that were done includes the analysis of target lesion failure using a protocol definition of target vessel MI, but you biostatisticians will like this, a relative non-inferiority margin, which is much more appropriate for the higher levels of observed TLF that occurred, or an analysis of TLF using the SKY definition of target vessel MI, which takes into account and accommodates troponin with a differential threshold and also incorporates clinical correlates. Both of these proved with a high level of statistical significance. Svelte was not inferior to Xience Promus. This has gone with the FDA. They've gone over this. This is clear. It wasn't that Svelte was not non-inferior. It's that the trial became progressively underpowered and couldn't prove it, even with 1,630 plus patients. So I think what this trial will do, it'll get Svelte approved this year by the FDA. It'll also inform other trials. In fact, we've provided these data to BRAM. Greg Stone is collecting this, looking at high sensitivity troponin, which has never been validated. This is a real problem going forward in clinical trials. I mean, the upper limit of normal in our hospital is 0.03 for troponin I. So 0.09 gives you a target vessel MI. It becomes kind of ridiculous. So this is where the disparity between where the clinical trials are, definitions and endpoints, okay, and biomarkers used, and where the hospital systems are going in the country. Another device that I think you'll see approved by the FDA this year, it's the first ever by a Chinese company looking to break into the US DES market, is Buma Supreme by Sinomed. Did you guys work with this device? You did. I thought higher profile, a little harder to deliver, but the selling point, as you will hear, is on pro-healing, okay, and quote, safety. This is a 3-component device. The first component, the outer layer, is a biodegradable PLGA polymer loaded with Cyrolimous. This is placed atop a proprietary electrografted PBMA coating, base coating that serves 2 purposes. It interdigitates with a PLGA to prevent flaking, cracking of the polymer, and when the polymer resorbs, it provides surface modification to accelerate or facilitate endothelial cell coverage and healing. The third component is an 80-micron thin cobalt chrome platform. The pharmacokinetic profile shown on the left is rather rapid. Over 90% of the drug is released in 28 days, and this is arterial Cyrolimous concentration of the wall of a pig artery peaks at 20 days. The PLGA polymer with Buma Supreme resorbs in 2 months, 45 to 60 days, much more rapidly than the PLGA with Synergy. And this reflects a difference in the LG ratio. The LG ratio in Buma Supreme is 50-50, Synergy is 85-15, and that really is the rate determining factor in the time course for resorption of PLGA. Buma Supreme appears to promote functional healing. If you look at the bottom left, we're using V coherent staining as a reflection of endothelial cell junction maturation and function. Buma Supreme exceeds Xience. And if you look on the right, using Evans blue uptake as it reflects endothelial cell junction permeability, and this has been correlated with the development of neoatherosclerosis, Buma Supreme is significantly less than Xience. This is the most recent data on Evans blue staining endothelial permeability with Buma Supreme. This came from Rainer Vermani's group, published last week, and you can see Buma Supreme is significantly less than Xience at both 45 and 90 days. I found this interesting for those of you who look at endothelial healing of stents, is the cell morphology and cell shape index, the AB ratio. This is more normal to be more flat. Buma Supreme is significantly better, if you will, more normal than Xience or Synergy. And this is a bare metal stent. Now, obviously, the key here is whether this translates into clinical outcomes remains to be seen. Pioneer 3, the pivotal trial for FDA approval. Buma Supreme randomly assigned 1,632 patients 2-to-1 to either Buma Supreme or Xience Promus. TLF powered for non-inferiority at 1 year as the primary endpoint. TLF in the Buma Supreme group is 5.4%, Xience Promus 5.1%, the p-value for non-inferiority 0.002. So the primary non-inferiority endpoint was met, and there were no differences in any of the TLF components or stent thrombosis. Diagnosis of TBMI in this trial required a greater than 5-fold elevation in either CKMB or troponin, but also required clinical correlates, which was a big difference. I think this is the first fundamental innovation in metallic implant design of the last 20 years. It's called a Dynamics Bioadapter. It is a thin strut, 71 micron thin cobalt chrome platform. It has a conformal surrounding the strut bilayer polymer. The outer 3 microns are PLGA, inner 6 microns PLLA, and the drug is Nivolumous at a dose density of 5 microgram per millimeter squared. A distinguishing characteristic of this device are these uncaging elements. These are specifically crafted struts. They're interdigitating, swathed in polymer. As the polymer resorbs over 3 to 6 months, these struts can uncage, disengage, and restore the capacity for vasomotion and adaptive positive vessel remodeling. Dynamics Uncaged appears to restore pulsatility and cyclic strain. This is actually a human. This is from the 50-patient proof of concept trial recently published by Stefan Verhey and Antonio Colombo. And this is 12 months following device implantation. Stationary OCT acquisition, co-registered images analyzed in a core lab. You can see systematic variance in lumen and stent area between systole and diastole. Dynamics Uncaged appears to reduce geometric distortion. Uncaging is associated with a 60% increase in conformability. On the left is a 120-degree angled mid-LED target following a 3-5-18 bioadapter. There's more than a 10-degree angle shift in this target. At 12-month angiographic follow-up, the vessel has resumed its normal configuration. And last but not least, Dynamics Uncaged appears to restore positive adaptive vessel remodeling. This is in vivo OCT evaluation, adult porcine coronary model, and the vertical axis is mean area. You can see of the device in orange, the lumen in green. The reduction in lumen area reflects the development of neointimal hyperplasia, which then recovers back to baseline and beyond with continued device growth. Now, does that happen in humans? It appears to, at least humans that have simple target lesions. According to Verhey and Colombo, this is the IVUS sub-study from their paper. Post-procedure and at 9 or 12 months, 2 cohorts combined for this analysis. You can see that vessel area increases slightly. Bioadapter area in stent area increases slightly. Lumen area is maintained. This is supported by the QCA data in the same patients, post-procedure and at 9 or 12 months combined. This is in bioadapter, in stent, late lumen loss, mean median of 0.11 and 0.03. What appears to be occurring here is that we know with second-gen DES, they cage the vessel. The lumen can only go in one direction. That's the wrong direction as it fills with neointimal hyperplasia shown here, but also neoatherosclerosis or thrombosis. Dynamics Bioadapter appears to have the capacity to increase device and vessel area and to accommodate neointimal hyperplasia, disease progression, and to maintain flow lumen area. We're working with FDA right now and hope to initiate a US IDE study before the end of the year. Over the past 20 years, there's been a remarkable evolution of drug-coated, drug-eluting balloons as well. As you know, the first generation paclitaxel-coated balloons are approved for peripheral use in the U.S. They employ crystalline and non-crystalline amorphous coatings that are fraught with challenges of particulate debris, microembolization, drug loss in transit. You know, it's been estimated by Juan Granada that only 10% or less of the drug on the surface of these devices actually gets to the target tissue. The second generation Cyrolimous coated balloons are coming to America. I think you'll see 2 in IDE trials before the end of this year. They use Cyrolimous, but they have widely variable coating technologies. The Concept Medical Magic Touch, it uses nanoencapsulation of Cyrolimous between 2 excipients. The Med-Alliance Solution balloon actually uses a polymer, PLGA transfer membrane, to move Cyrolimous. In the Sequent Please Cyrolimous uses a spray-on V4 excipient. The efficiency of drug transfer is significantly improved and appears to be 40% or more of the drug on these devices gets to the target tissue. And then there's a third generation Cyrolimous eluting balloon. Cyrolimous is the drug, but there is no coating, no particulate, no drug loss in transit. This is the Virtue Cyrolimous angioinfusion balloon. It has an angioinfusion balloon catheter. This has 5 to 6 micron laser drilled pores in the surface of the balloon and uses a proprietary bioresorbable nanoencapsulation technology called Cyrolimous CFR, or extended focal release. All I'm allowed to say is that there are little packets or pillows of Cyrolimous that are extruded through these pores into the wall of the vessel where they undergo programmed resorption over time. This yields a pharmacokinetic profile shown on the right using normalized tissue kinetics. That's normalized for day 1 concentration with Virtue in red, as you can see. It mimics the pharmacokinetic profile of Cypher and Xience DES out to 30 days. Virtue achieves a therapeutic concentration of Cyrolimous in the wall of a pig artery that extends out to 30 days, as you can see, with little drug lost in the kidney, liver, and lung. Now, the pivotal trial for U.S. FDA approval will focus on ISR, that's in-stent restenosis. As you know, this is an incredible void in the U.S. armamentarium. The 2014 ESC guidelines of myocardial revascularization, right, give a class 1 level of evidence, A, recommendation to drug-coated balloons in the treatment of DES or BMS ISR 7 years later in the United States. We don't have a single device close to approval. Patients that have 1 or 2 stent DS or BMS ISR that satisfy these lesion of vessel criteria, if it's a 1 stent ISR, they'll be randomized 2-to-1 to Virtue versus POBA. Many of you may not know this. POBA is one of 3 precedent devices, that's plain old balloon angioplasty, approved for the treatment of ISR in the United States. Those devices are POBA, Taxus stent, which is extinct, and vascular brachytherapy. Believe it or not, those are the only 3 devices approved by the U.S. FDA for the treatment of ISR today. POBA-treated patients will have the ability to cross over to Virtue treatment if they have clinically driven recurrent ISR within 12 months. And the primary endpoint here is target lesion failure powered for superiority. 2-stent ISR, a double layer of metal, will be single arm, open label, Virtue treatment. Secret, look for a second IDE. This will be small vessel, 2.5 and less. It'll be randomized to either Virtue versus small vessel DES. And I think this is the next horizon for drug-coated balloons. It's already happening in Japan, where drug-coated balloons are well over 15, even 20%. And it will cannibalize probably 25% or more of the U.S. stent market. Now, quote my good friend Antonio Colombo, why put metal in a small artery unless you have to as a default strategy? Vascular calcification is becoming a bigger and bigger problem for all of us. Never in our history as interventionists has this been a bigger problem. Increasing age of the population, prevalence of diabetes, chronic kidney disease, hypertension. It impacts vascular access with large bore catheters that we use more and more, and it also impacts the outcomes of PCI. In this meta-analysis of 7 contemporary PCI trials with clinical outcomes through 3 years, we see that patients that had severe target lesion calcification have an increase in death MI, repeat revascularization. You know, I've often said that calcium is the gift that keeps giving. If you look on the left, these are the Kaplan-Meier curves for death MI, repeat revascularization. They continue to diverge over a 3-year follow-up with incremental hazard associated with the presence of severe lesion calcification. On the right, with a 1-year landmark, beyond 1 year, there rapidly evolves incremental hazard associated with severe lesion calcium, likely reflecting very late thrombosis and restenosis. Well, calcium impacts the symmetry, apposition, and expansion of stents. The greater the arc, length, or thickness of calcium, the greater the likelihood of stent under expansion. Asymmetric stent expansion has been identified in half of the stents placed in calcified lesions, and by multivariate analysis, stent under expansion is the most powerful predictor of stent thrombosis or restenosis. If you look on the right, this is the relationship between the arc of calcium in degrees on the horizontal axis to the degree of stent expansion at a 16 atmosphere deployment on the vertical axis. It's very simple. If you draw a line from 180 degrees, no one that has an arc of calcium exceeding 180 degrees achieves more than 90% stent expansion, which is really a benchmark for optimized outcomes. You know, we're fortunate to have a therapeutic algorithm for moderate to severe coronary calcium. This is, of course, the SKY position statement co-authored by two of my partners, Rob Riley and Tim Henry, your very own Tim Henry. And I think this is very important because it incorporates these calcium modifying technologies in the toolbox down here in the bottom right, and it stresses the importance of imaging. If you have a non-dilatable lesion starting here in the upper left, you really should do intravascular imaging, preferably with OCT, and measure the arc of calcium. If it's greater than 180 degrees, based on the data you saw on the last slide, you get 2 points. If the length is greater than 5 millimeters, 1 point. If the thickness is greater than 0.5 millimeters, 1 point. This is, of course, the 0 to 4 point calcium volume index scoring system that if you have 4 points, your likelihood of having stent under expansion is extremely high, and you should reach into that toolbox and, as we say in Cincinnati, get you one of these calcium modifying technologies. If you have a 0 to 2 score, you may want to give it a go with an NC cutting or scoring balloon. I think this is very useful and employs images. This toolbox starts in the bottom left. It includes NC cutting, scoring balloons, rotational orbital atherectomy, laser ablation, and most recently, intravascular lithotripsy. You know, one of the challenges in atheroablative technologies has been wire bias of effect, and this is clearly evident in these OCT images given to me by Akiko Miyahara. You can see this incredibly eccentric rut or trough that engulfs the wire in OCT catheter, almost looks distinct and separate from the lumen of the vessel. Similarly with orbital atherectomy, you can see this eccentric rut or trough that's created as the device rides the wire. And if you look at the upper right-hand corner, this is an incredibly beautiful, deep arc of calcium on OCT. Ask yourself how that device is going to access and modify calcium at the depth of that asterisk in the absence of extreme wire bias or increase in size of the burr or crown, none of which is attractive. Well, intravascular lithotripsy applies a technology that's been used for over 30 years to treat kidney stones. Acoustic pressure waves are generated from emitters placed on the shaft of a balloon angioplasty catheter. They emit 1 wave per second each a millisecond, transmitting 50 atmospheres of pressure in a circumferential transmural fashion. The balloon is inflated to 4 atmospheres, 10 pulses are given. The balloon is then inflated to a nominal 6 atmosphere pressure. If full balloon inflation doesn't occur, the balloon is deflated, reperfusion occurs, and the cycle is repeated. Eventually, full balloon inflation at a nominal 6 atmosphere pressure should occur. The mechanism appears to be circumferential longitudinal calcium fractures, as shown in this post-IVL OCT. We actually took this out of the JACC paper for CAD3 because it was too large for a central image. You can see here on the bottom right, this is fracture expansion by stent deployment, which is one of the mechanisms for increased transmural compliance. Well, Disrupt CAD3 was a pivotal trial for U.S. FDA approval as a prospective multicenter single-arm global IDE conducted in 4 countries. Patients with heavily calcified de novo coronary lesions were enrolled, and this definition includes radiopacities on both sides of the vessel, at least 15 millimeter length by angiography, or a calcium angle at least 270 degrees by intravascular imaging. One roll-in patient per site was allowed at each of the 47 international sites, and in addition, there were 384 patients enrolled into an ITT population from which the primary endpoints were discerned. Now, the primary safety endpoint was freedom from MACE at 30 days. This is the exact same safety endpoint used in the Orbit-2 trial, the pivotal trial for orbital atherectomy approval, and the primary effectiveness endpoint, procedural success, again, the exact same effectiveness endpoint used in the Orbit-2 trial. That said, the primary safety endpoint, freedom from 30-day MACE, was observed at 92.2%. As you can see, the lower confidence bound far exceeds the safety performance goal established from Orbit-2, and the primary safety endpoint was met. The primary effectiveness endpoint, procedural success, observed at 92.4%. Again, the lower confidence bound far exceeds the performance goal established from Orbit-2, and the primary effectiveness endpoint was met. This slide shows in-hospital and 30-day MACE rates of 7 and 7.8% respectively, along with the individual components of MACE. If you recall, in Orbit-2, using a similar population, similar endpoint, similar definition, the 30-day MACE rate is 10.4%. These are the angiographic complications. Post-IVL, 2.1% of patients had complex type D through F dissection. This was reduced to a single patient, 0.3% following stent deployment. Note that perforation, slow flow, no reflow were 0 post-IVL. I'll add that this has been expanded with core lab adjudication, 628 patients. The revision is going back to JACC-CI this week. Robbie Riley will present it at ACC as an oral abstract. In 628 patients, these numbers are unchanged. IVL-induced ventricular capture, certainly a curiosity, but it's really common. 41% of all the patients in this trial had IVL-induced ventricular capture without any sustained ventricular arrhythmia or clinical sequelae. It's more common in patients that are bradycardic to begin with. The drop in systolic blood pressure during the procedure is more frequent in those with versus without IVL-induced ventricular capture, but the magnitude of systolic blood pressure drop was not different between these groups. You know, every novel technology has a learning curve, and this slide shows the first case at each of the 47 international sites in orange, compared to the subsequent 384 patients that were enrolled into the pivotal ITT population in blue. The clinical and angiographic characteristics of these populations were similar, and remarkably, the clinical outcomes, whether it's the primary safety endpoint, the procedural success is the primary effectiveness endpoint, or even device crossing, were quite similar. These are the OCT measurements presented by Rich Schlafmitz at TCT. There's a 100-patient OCT substudy as part of CAD3. The maximum calcium site, which is defined mostly by the calcium angle, the largest calcium angle. If there was a tie-on angle, then the thickness was used to determine the maximum calcium site. The average calcium angle is 293 degrees. Think about that. 180 degrees is the risk predictor, gives you 2 points. At that site, the maximum calcium thickness is almost a millimeter, 0.96. Greater than 0.5 is a risk predictor. And they all have 5 millimeter length. So this is a 4 calcium score. And the average stent expansion is 102% in the MSA, or minimum stent area, 6.5 millimeters squared for the group. You know, I'm often critical of people that do cross-trial comparisons, but I think, as most of you know, CAD3 was designed with performance goals derived from Orbit-2. Similar population, designed that way, similar endpoints, similar definition. That said, as you can see, CAD3 really dwarfs Orbit-2 with respect to target lesion length, calcified segment length, for the trial as a whole on the left, and for the long lesion subset. That's defined as a 25 millimeter or greater lesion length. That subset has been published on the far right from the Orbit-2 trial. That said, if you look at the primary safety and effectiveness endpoints, they're all greater than 90% for CAD3, regardless of lesion length. Not so for Orbit-2. Less than 90% for the trial as a whole, less than 85% for the long lesion subset. Well, in conclusion, I'd say that stent-related adverse events are influenced by stent strut thickness. The role of strut geometry, round versus square, remains to be determined. This 2 to 4% annualized rate of adverse events that occur beyond 1 year after stent implant, regardless of device, appears related to the common presence of a metallic prosthesis that constrains and distorts the vessel. The impact of Dynamics Bioadapter, which will be billed as high-performance second-gen DES with the capacity to behave like a bioresorbable to the extent that it can uncage and allow positive adaptive vessel remodeling, a hybrid device. That'll be the wrap when you see it going into a clinical trial, hopefully by the end of this year. Drug delivery without a scaffold will enter IDE evaluation for the treatment of ISR. Initially, small vessels, you'll see it in small vessels, I think, if not by the end of this year, probably in 22. Where stent strut thickness and volume is really, the impact is exaggerated. It makes sense, and I can show you the data just on the physical capacity of small vessels for stent metal volume or strut volume plays a larger and larger role. Vascular calcium increases early and late complications after stenting due to stent malposition and under expansion. And I think you've seen that IVL safely improves transmural vessel compliance and reduces fibroelastic recoil, mitigates the need for high-pressure balloon inflation with associated barotrauma. It seems to have its effect by creating multiplane circumferential longitudinal calcium fractures. I'll acknowledge, and one of you should ask me, why did 30% of the patients in the OCT sub-study not have visible fractures by OCT? That's true. In part because some of them are out of plane, we missed it. In part because they may be beyond the resolution of OCT, I'm not kidding. The preclinical data suggests that micro-CT data that there are fractures that will be missed by OCT, and in part by the fact that there may be other mechanisms by which IVL alters transmural compliance and facilitates stent expansion, which it clearly appears to do in a fairly safe and predictable way. There may be other mechanisms that we don't understand at this point. So thank you very much for your attention. I hope I kept reasonably on time. Manos.
Congratulations. That was an amazing overview of the contemporary PCI field that you've been shaping over the years. Quick question on the practical aspect. So IVL is obviously very exciting for everyone, but we're just going through the approval process, and as you know, the cost is prohibitive for many aspects. Oh. So any questions or any advice on that? And then also in terms of the terminology, is it lithotripsy, is it lithoplasty? What is the correct term to use? I know both are used in different
I use lithotripsy. I mean, it is lithotripsy. And you know, when they applied it in a balloon, we have a mechanism of action. I haven't seen the proofs yet. It's called Principles of IVL for Intravascular Therapy. That'll be coming out, maybe reviewed at, I don't know, at JACC-CI. But it's, they really took, when you look at extracorporeal lithotripsy, it has a very high positive wave and a very negative, shock, a negative wave, pressure wave. And that was what damages tissues. This is a fraction. I mean, I can show you, you'll see it. They modified the contour of the wave, the energy is way down, and the fluid is there for a reason. It actually dissipates heat and it removes cavitation, when you suck the balloon down. So it's actually an ingenious application. I think, and I wasn't involved in the pricing, they asked me, actually Doug Godshaw asked me, and I said, price it between orbital and rotational, and you won't be able to keep it on the shelf. The thing will fly off the shelf. People will use it on every case. And the problem is, where they priced it, they did it for a reason, because it's a breakthrough technology. They're working with CMS, kind of like what Impella had, where they, a lot of the use of Impella, frankly, I mean, we're all in these big programs where for supported PCI, if you use Impella, it's like a $35,000 tick. Your contribution margin for that case, if you perclose them, take it out after the procedure, pretty high. It works. financially for the hospital. And I'm not saying that that should drive any of our behavior, but man, I live in the same world you guys do. I think what's going to happen is that hospitals, there's a honeymoon period now. You know, we've got Rob Riley who wants to use the shockwave on everybody, and the administration is going to put the cap on that. And you're going to have to justify on a patient-by-patient basis why you want to use IVL in this patient. Does this patient have an arc over 270 degrees? Does this patient have calcium angiographically on both sides of the vessel, at least 15 millimeters in length? I'm serious. How would you do it as a hospital administrator? Think about it. That's what you have to do to selectively use it. What drives it, and people will say it's counterbalanced, offset, because the complication rates are clearly lower. I threw in the 628 patient analysis. To the best of my knowledge, I've not seen perforation with that alone. The microperf that occurred in our study didn't require any therapy. It was a blush, and they didn't have to tap the pericardium. Patient went home the next day. That was after stent was placed. We think the adventitia keeps the arteries from, you know, most of these patients with advanced disease and calcium, they have very thick adventitia. You travel in the adventitia sometimes, I know. And this is, and it holds the arteries. It reduces the likelihood. So when you see the fractures, the biggest thing that happened was the fractures, which are circumferential and longitudinal. When you put a stent in, they expand dramatically. And I think the reason the arteries don't rupture or perforate is because of that fibrotic, what occurs in the adventitia, which is fibrosis. Is that correct? Yeah, so that holds the arteries together and you're able to expand them. The safety is predictable. It's reliable, more so, you know, than the atheroablative technologies. And it doesn't have wire bias of effect. It's kind of ingenious. It centralizes, you know, when you put the balloon up, so that the emitters are in the center and they get circumferential penetration. So I just have no control over why they priced it this way. To me, it was a huge disappointment, to be very honest. But maybe within 6 months, they say there'll be incremental reimbursement, and then people will maybe want to use it kind of like they use Impella now sometimes. Okay. Yeah, Scott?
Thank you, Dean. That was really an excellent talk. In the context of the improvements that you're showing us with the stents, what are your views about where prophylactic stenting might head?
Yeah, that was Greg's absorb. He always wanted to pave, you know. That goes way back. Some of you guys are old enough to remember. The guy that started Syncardia, Marvin Schleppian, had his original thought process was gel paving. You remember that concept? Maybe you're not old enough. We call it the Clearasil approach to the artery. You want to medicate it, but you don't want to put a scaffold in it. You don't want to put material, okay, hardware in it. And what Greg has done, which is very intriguing, is looked at individuals that have large lipid pool, that have, you know, TICFA morphology. They have plaque burden, you know, is over 70%. They have the characteristics that we know are going to be vulnerable, are going to be causing a problem downstream. And you put a bioresorbable scaffold on it to medicate it and also to seal it. And we saw that early on. One of the intriguing things with the absorbed BVS, you remember, was that golden lumen that Patrick Sorois would talk about, the sealing of a plaque concept. And that was actually identified in some people, some patients, by OCT at late follow-up, you know, 3 and 5 years later. So I think what DES become a commodity right now. That's it. I mean, everybody wants DES for $500 or less. You know, we're trying to juggle the prices. And I think that the Bioadapter offers the capacity for deliverability, which BVS didn't have, and yet still the uncaging. And I talked to both Stefan and Antonio. In fact, I'm a co-author on that paper. Is that it does release. And at least at that follow-up, 9 and 12 months, there are those findings that you see. So it looks like with simple lesions, and this is not heavily calcified disease, you can get the ability to restore positive adaptive vessel remodeling. And people ask, what is the number one benefit of a bioresorbable? It's that. Positive adaptive vessel remodeling is the protective mechanism that nature gives us to accommodate atherosclerosis. If you had to pick what is the most important thing that our arteries do, it's adaptive remodeling, okay? I mean, I think, because it allows us to accommodate atherosclerosis to an extent, much greater extent than we would otherwise. So I think if that works, it'll be very effective. I don't know about treating non-lesions. You know, the guy who tried to do that in California went to jail. You remember that? And he actually had a great concept in retrospect. You guys remember bypassing vulnerable lesions? I think we're not quite ready for prime time, but I get the concept, and if patients are willing to submit like they did for Absorb that Greg just presented, which is really the next step beyond his prospect trial, which, you know, you identify the vulnerable plaque, you identify what it looks like, and then you pave it. Here with a bioresorbable, Marvin used a gel, which is resorbable, but that medicates the vessel. I think that that's a really good objective and a place we can go. I think if we don't have to leave hardware in, it's the best. I mean, at the end of the day, that's why I think you're going to see these balloons, and now Boston's entered it. They have their agent trial. It's a paclitaxel. I'm surprised the FDA didn't give them more trouble than they're giving Virtue. I mean, Virtue, which leaves nothing behind, you know, it doesn't have any particulate microembolization, no drug lost in transit, and has been identified as a breakthrough technology that they're still getting jacked around, if you will, by FDA. FDA's been very interesting. In some ways, they've accelerated, made the pathway, I won't say easier, but more expedient. But in other ways, I really can't figure it out. It depends on, it's like a Russian roulette, who you get as a reviewer, really, sometimes.
That was a phenomenal talk. I have a follow-up question related to non-coronary applications of IVL. I'm thinking aortic stenosis, mitral disease, heavily calcified. How do you see that moving forward?
Well, they have a device that they've been working on for aortic stenosis, and it was to soften the leaflets. This could be used or maybe earlier. It may prevent or retard the need to have valve replacement, okay? It could be palliative in people that are really high risk, that you don't. They've also used looked at the application for that for MAC as an example. I think for large vessels, it's been a huge savior. I mean, my first exposure was getting access for TAVR. And you've seen with the Impella mechanical cardiac support, EVAR, TVAR, TAVR, MCS. I mean, this is just transforms. I think 8 out of 10 of these no femoral access you can transform into. And the really remarkable thing about that, Sandy, is that you don't have to bail out stent. If you look at Carlo DiMario's 42 patients and put it as a letter and jack, maybe one stent was placed. And you get this MLD, it looks like a stent-like result. And I think because that 85% of those balloons were 7 by 60, you know, which is the largest balloon that they have for the iliacs. When you get done, not only does it increase the MLD, it also, much of what we see in fibroelastic recoil is due to the calcification, is calcium. And the snapback. So you get a stent-like result with the balloon only at relatively low atmospheric pressures. And so it's not that common that we have to bail out to stent, where we've been. Have you had the same experience here? I mean, we don't, and we've used it on subclavian to get in, at the ostium of the left subclavian if we're going to use it for a TAVR access. Sometimes it's got the Cheerio sign, circumferential calcium. You can actually fracture that and get past it. you can use it for other arteries. Well, I think it's, as far as its valvular applications, I think that's a ways off. You saw probably the cases that were done in South America. They've changed that device too, so it's a little different. I don't know, I mean, at this point, whether that's going to be applicable. Most of the valves we get, they're not going to be safe. I mean, if you're going to do something, you're going to temporize, but they're already a mess, you know what I mean? They're already heavily calcified, so maybe moving that therapy upstream might be helpful. Well, yes. Yeah.
We have just one online question thus far. This comes from one of our interventional cardiology fellows who asks, or wanted to ask you what you think the mechanism of coronary dissection was in the Disrupt CAD trial, even though the balloons were only inflated to 4 to 6 millimeters.
Yeah, no, they do have dissection. You can see it. How much of that, we've been arguing with reviewers over how much is heat, what's the healing process, you know, late. I mean, will they have increased restenosis like was said for rotational atherectomy, right, at one time because of heat, the burr? We don't think so. There are dissections, but it's very interesting that it appears to be relatively stable. Most of them are stable. And I think there's a lot more, when you rip an artery with a high pressure 20, 30 atmosphere balloon, it's very different than if you fracture the calcium to facilitate low pressure balloon inflation. And I really think that's the difference. One of the questions we've been asked is, why is there such a difference in the number of pulses? Some people get this many pulses, some people get this many pulses. And, you know, how did you? Well, you got two schools of thought. If the balloon opens at a nominal 6 atmosphere pressure and you size a 1-to-1, you're done. I mean, that's what we would do. We'd move the balloon to the next site up and down the lesion because it's only 12 millimeters long. Schlafmitz will OCT him again, and if he doesn't see a fracture, he'll go in and just keep delivering pulses. You see what I mean? Until he sees. So he kind of uses OCT to determine whether he's done or not. And he will give 80 pulses, he exhausts the balloon every time. And I don't know who's right, but I think in general, if you give X pulses and you get full inflation of a 1-to-1 size balloon at 6 atmosphere, nominal balloon pressure, that's really remarkable. I might ask for somebody like yourself, Manos, you've been doing this for a long time now, how many times do you get full balloon inflation in a heavily calcified artery at a nominal pressure? Not very often.
Never tried.
Yeah, never tried. Yeah.
So Dean, have you evolved over this? What percentage are, like in a typical lesion, how many pulses are you giving? And are you erring on giving more? And then what's your thought on when the total number of pulses is too much?
Yeah, we don't know what is too much, I'll be honest with you. In other words, you know, there's no apparent damage to normal tissue. It just fractures calcium, okay? I give the pulses until I get full balloon inflation at a nominal pressure.
And then you stop.
I stop. Since then, I may give another round, you know, of 10 pulses, just because of watching Schlafmitz, you know? I mean, it's probably not going to hurt, and it may make it better. I don't know. I don't think anybody knows. The fact is, you only got 12 millimeters, and you have that because these things are not deliverable. You know, the material they put in there for the emitters and the wiring make it less trackable, less flexible. You've done this. Use off-label the S4, which has got 4 emitters, or the M5, you know, from the periphery. It's a joke, you know, if you try to put these down coronaries, and they won't go. So they had to make it 2 emitters, 12 millimeters in length, so that it was more deliverable. And even that can be a challenge at times, can be.
And so if you had a case where you had to use a second one?
Yeah, and a couple times they'll break too, not as much. They had thinned the balloon material to make it lower profile. There were several ruptures, if you will, early on in the trial. They went back to the thicker balloon skin, balloon material. So they've had less overall. But that can happen. When it happens, it's not been a big deal. There's one case report, you guys saw it, from Europe where somebody had a contrast dissection. I couldn't figure out how that happened, to be honest with you. And neither can
what
doctors.
percentage are you, now after into usage, what percentage you think will you use OCT in conjunction?
Yeah, I think the OCT use will go up, but again, in the US, imaging, I'd say standard would be less than 15% of all cases, clearly. Even though imaging has gone up, it's gone up selectively. For example, the NCDR said that left main, that 60% of the PCI of left main in the United States was done without imaging. 77% in Excel had imaging, right? 80%. So imaging is used more selectively for certain targets. I think now imaging, particularly IVUS, is being used more for left main in the US, as it should be. But it's been slow to evolve. And I think part of it's a reimbursement issue too. It really is. And time.
But the experience with IVUS with IVL is a lot less.
It's less.
So the question is, if you're going to use IVL, would you use OCT?
I don't think you can image the cracks. Yeah, you should use OCT. The cracks in the calcium are much more obvious with OCT. You can see them. And I think OCT is a better technology for that. For imaging depth of calcium, you agree?
Are you imaging them, all of them?
We use off-label, we don't have the coronary, but we image most of them. I do IVUS quite a bit, I must say, but for me, balloon expands, as you say, then the imaging is more precise than the stent and
Yeah, we used a lot of the S4s, the BTK balloons, because they're 2.5 to 4.0, but they're 40 millimeters long. We used a lot of those during the trial for off-label. We give referrals. Somebody send me a left main, it wouldn't qualify for trial enrollment. So you can't say, no, thank you. You can't tell the doc, no, you say, no problem, we'll do it. And you just do it with an S4 off-label. And very effective. They don't go up and down very fast. So if you're doing left mains, you need some support because otherwise patient crumps.
I mean, the cost is a huge issue, and we're trying hard from a SCI standpoint to try to increase reimbursement for imaging, but it's a hard battle.
Yeah.
And you look at it, if you look at imaging overall, it clearly makes a difference, right? It decreases target vessel failure, right? Which is really restenosis. So what you're doing is you're automatically increasing the cost for the hospital for each case, and you're taking away restenosis, which saves them, which is a lot of good money. So from a cost to the hospital, but for a benefit to the insurance company, it should be there. And so you should get reimbursed, but trying to fight that battle it's way more difficult than you would think.
Yeah, now there are hard endpoints too. The BCIS data for left main show improved survival 1 year, right? With imaging versus no imaging in left main.
I think left main is straightforward. I think you're crazy to not image left mains, right? Don't you think?
Yeah.
I think it should be close to 100%.
Yeah, and I think it's moving in that direction. I really do. So, hey, listen, you guys have been great. I really appreciate your time.
Thank you.